we are looking at the genera Rickettsiae itself. Then we have Rickettsiae, as the name suggests, these are the newer bacteria under the genus Rickettsiae, but different enough genetically to have their own genera. We have Orientia, Alicia, Neo-Alicia, Anaplasma, Coxiella, and Bartonella. So Bartonella has since been reclassified. That's why it has a star, but we're still going to discuss it under the Rickettsiae. So the transmission, as we said, is by arthropods, of these bacteria is by arthropods. So most are transmitted by ectoparasites. This could be fleas or lice or mites and ticks. And this is during the feeding of the ectoparasites on the infected animal. But also squashing of crushed arthropods or infectious feces into the skin, causing a breach in the skin. And so the bacteria can enter the body. Inhalation of dust or inoculating of the conjunctiva with infectious material. We see this with the genus Coxiella, highly infective. Transfusion or organ transplantation also. This is rare but has been reported. And this is because it's not routine to screen for these infections. Now, these are widely distributed globally, but we do have endemic foci. These are foci where some of these bacteria are more commonly found than others, but they have the ability to spread globally. And in these endemic foci, we see sporadic and seasonal. No, we are not on parasites, good Lord. This is bacteriology. Now, sporadic and often seasonal outbreaks. So in these endemic areas, so all age groups at risk during travel to endemic areas. So anybody traveling to an endemic area, regardless of age, can get the infections, and transmission usually is increased during outdoor activities because obviously, as we say, they are transmitted mostly by ectoparasites, and these tend to be outdoors. An infection can occur throughout the year, and you shall see that the incubation period for most of the rickettsial diseases are about 5 to 14 days. Okay, so let's look at the first genus, which is Rickettsiae itself. So as I said, you need to be careful because you can be asked to discuss the Rickettsiae. So you can pick any of the genera or to discuss the genus Rickettsiae specifically. So be careful with the spelling. So classification usually is based on the kind of infection that it causes or the major manifestation. So may be classified in the spotted fever group Rickettsiae, in the typhus group Rickettsiae. We have the Rickettsiae belli group and the Rickettsiae canadensis group. So, but the commonest ones that you'll find are the spotted fever group and the typhus group Rickettsiae. So these are the ones that you need to remember. Now for the spotted fever group Rickettsiae, there are many species here, and they are mainly, not all, mainly transmitted by the ixoid ticks. I've not done entomology yet, but ixoid ticks are the hard ticks. Ticks can either be soft ticks or hard ticks. Hard ticks are mostly connected to being transmitters of disease as opposed to the soft ticks. So ixoid ticks are a kind of hard ticks. And sometimes because of this, the spotted fever group Rickettsiae are also referred to as a tick-borne rickettsiosis. But this should not confuse you. Not all of them are transmitted by ticks, but most are transmitted by ticks. So we have Rickettsiae africae, which is important to us because this is what we find in our setup. Then we have Rickettsiae connori, Rickettsiae rickettsii, which was the very first species of Rickettsiae to be isolated or to be discovered. Then you have Rickettsiae acari. Now this one is transmitted by mites. Then you have Rickettsiae felis, which is transmitted by a flea. So from the species name, you can see it's related to feline. So related to the cats, first isolated from cats. It's transmitted by the fever. Diagram shows distribution of the tick-borne viruses. So you can see almost all continents. They have been discovered in almost all continents. The very first one was the Rickettsiae, which was first discovered in America. Then you have the other. So Rickettsiae africae is important to us. Then we have all the others. Mostly the species name will take the name of the place that it was first identified. So which are these infections that these species cause? The very first infection to be identified was the Rocky Mountain spotted fever, which is caused by Rickettsiae, which, as I said, was the very first species to be identified. Then we have the Mediterranean spotted fever, also referred to as nose fever. And this is caused by Rickettsiae connori. We have the African tick bite fever caused by Rickettsiae africae. Then we have Rickettsiae pox, Rickettsiae acai, Then the newest one, because it's not new in the last 6 months, but the newest infections to be described are infections, and these were first described in apathy, well, the ones were the obligate hematophagus insect. So every time you see obliquely without whatever it's obligated to. So in this case, these insects have to have a blood meal to survive, hence the name obligate hematophagus insects. So the first one was Rickettsiae prowazekii, and this causes epidemic typhus. And this is transmitted by the human body louse mostly. So we have this scientific name is Pediculus humanus. But the human head louse, Pediculus humanus capitis, has also been implicated. So why is it epidemic? This is found in areas of close proximity. So people are living in close proximity. It is a disease of poverty. It's one of those water-washed diseases. So they have lice, and the lice can easily spread if people are living in close quarters, easily spread from one person to the other, hence epidemic typhus. So you tend to have epidemics of the infection. And then we have Rickettsia typhi, which is also referred to as murine typhus or endemic typhus. And this one is transmitted by fleas. So Rickettsiae prowazekii has been more studied, the two, and infections occur in 3 situations. So as we said, you can have louse transmitted epidemics. So there's transmission from person to person. As we said, it tends to occur in areas of overcrowding. So there's deposition on the skin of the louse feces, and then there's scratching because of the irritation. And this introduces the bacteria into the skin. So the scratching inoculates the rickettsia into the skin. So what happens between epidemics? So there's a latent human infection, and there can be a recrudescence later, years later, and this is what is referred to as the Brilzinsa disease. And then in areas where you have the flying squirrel, the reservoir, it acts as a reservoir for human infection. So zoonosis from the flying squirrel. I was muted. So pathogenesis of Rickettsiae. Rickettsiae enter host cells through induce the host nutrients, but they're also protected from the host's immune responses of infection occur. For the spotted fever group, Rickettsiae, it moves intra and intercellularly by active. It moves by host cell lysis. And so we expect that the typhus group will give the more severe infection of the two because it's causing a lysis of the host cells. So this is a diagrammatic showing the pathogenesis of the Rickettsiae. So we have induced phagocytosis. It escapes the phagosome before the phagolysosomal fusion. And for the typhus group, there's lysis. For the spotted group, it's usually through, as we said, actin polymerization. So what will a patient present with? Remember, we said for all the Rickettsiae, you will have a fever, so it's a febrile illness, and there's also some dermatological manifestation. So for the spotted fever, onset in 2 days after the infective bite, and they'll come. So very similar to what you will find if you're working in a malaria zone. But remember, the difference will be the presence of the skin manifestation, in this case, a rash. So the rash is characteristic, usually appears on the ankles and the wrists. And there are complications if this disease is not treated in time. So complications will involve partial paralysis of the lower limbs and also gangrene. And this is because of the blockade of the blood vessels. And of course, you know the complications of blockade of any blood flow. Now for the typhus fever, so fever, chills, headache, muscle pain, very similar. In this case, you get macules, which appear on the trunk and then to the extremities, and other symptoms of smallness or bleeding, conjunctival injection. You may have central nervous system manifestations for the same reason. The 2 vectors, what are they?
Flea.
So the flea, which is the flea?
Right bottom.
Yeah, right bottom. And then finally, top right, that.
Tick.
Which kind of tick? You have to be specific. Is a hard tick. Okay, so you're going to learn more about the differences between the soft and the hard ticks in entomology. But remember, the hard ticks are more often the vectors as opposed to the soft ticks. I think we all know the soft ticks, the ones that are very bulgy. The hard ticks are flat anterolaterally, and they tend to be more said are more commonly found as disease vectors. This shows spot difference is seen in the lighter skin. Okay, so someone says blood, that's correct. So it will be a blood specimen. So we get it into the lab. Now remember, these are obligate intracellular bacteria. Yeah, you have, how do we isolate? Well, your CSF, if they have CSF symptoms, you can also take a CSF sample. How do you isolate obligate intracellular bacteria? You've already covered chlamydia. How do you isolate in strict intracellular bacteria in a routine lab? Sorry? I don't hear you very well. Using
Cell culture.
Cell cultures. So fastidious agar. Which one is that? So she's not sure. She also puts a question mark. So yes, remember for obligate intracellular bacteria, you cannot isolate them. They are not free living. So you cannot isolate them in the media that we normally use. So you have to use cell cultures. You may have learned about the HeLa cells, about the chicken embryo, and so on and so forth. And so in a routine hospital lab, which tends to be level 2, you will not be able to isolate this, because anything that involves cell culture has a high risk of contamination, and also high risk of for the person doing the isolation getting infected. And so it's only done in level 3 labs and above, which most hospitals, in fact none, have the level 3 labs. It's tend to be research labs or the referral labs. And so at a hospital level, so you mostly use the immunological tests. So stain poorly with the Gram-stain, as we said, because of some characteristics in their cell wall. And so we use the James and the Jimenez stains. So the hallmark of identification or of diagnosis has been serological. So does this person have either the antigen or the antibodies to this? You may have learned about the Will-Felix reaction when you're looking at the protease. Now this has been what has been used, but it's non-specific. As with many immunological tests, it tends to have poor specificity and sensitivity. And so the indirect immunofluorescent assay is what has been used mostly. Latex agglutination can also be used. So the direct fluorescent antibody testing, if you need to isolate culture, you need this cannot be used in a routine reasons that we give. So the risk of laboratory acquired infection is very high, as with anything involving tissue cultures, which is why not done in a level 2 lab. So top left, that was a blood sample. No, this is not, yes, that was a blood sample. So this is Jimenez staining. I think GMs are either James or Jimenez staining. Either way, they appear red. So that is, I don't know if it's clear in the circular part. So that's a macrophage. You can see the nucleus, the blue nucleus, and the red organisms. Those are the intracellular Rickettsiae bacteria. To the right top, did I say left? So the top right, you can see some extracellular bacteria, but this is because this was sampled from the vector, not from the human. And so you'll find them extracellularly in the vector. At the bottom is the fluorescent antibody. So you look for the fluorescent. In this case, it's a positive test because you can see the yellow-green fluorescing bacteria. So the drug of choice, as you will find with most intracellular bacteria, the doxycycline, most Rickettsiae. Chloramphenicol has also been used, but remember, if we are doing pharmacology, so this has its limitations of use, which I hope you remember. Now, rickettsias, they tend to be highly antimicrobial resistance, but this, remember, cannot be isolated in the routine labs. Isolation is tedious, and so not much work has been done when it comes to the antimicrobial resistance testing or the susceptibility testing of the Rickettsiae. So prevention, control, obviously this is not exhaustive for you to talk about prevention and control, advising patients about how to prevent this. Then you need to give them an exhaustive list of what to avoid. So limiting exposure to ticks. We also talked about fleas. We've talked about overcrowding. So all those should go into prevention and control. So obviously control is an outbreak, but to control that. Second genus is Orientia. And species of interest is Orientia tutugamushi, which causes scrub typhus. So scrub typhus, very sometimes also referred to as tutugamushi disease, and it's transmitted to humans by the bite of the larva of the trabecular mites, also referred to as chiggers. So you learn about all these matters when you begin in third year. And it's endemic to the Tutugamushi Triangle, which is here at the top. We have a magnified image of the chigga, of the mite. It's actually microscopic. You cannot see it with your naked eye, but this has been magnified so that you can appreciate it. Okay, so what's the illness? Remember, we said all of these present with fever and some skin manifestation. So the illness varies from mild to self to very severe infections that can be fatal. Incubation period of 71 days, very similar to what we've covered: fever, headache, myalgia, cough, and some gastrointestinal lesion that appears as flat black scar. And this may be associated with regional and generalized lymphadenopathy. May have a macular rash, and if untreated, of course, you may have complications with the central nervous system like meningoencephalitis, as well as some cranial nerve deficits. So at the top is the characteristic flat black scar at the site of bite. And then you have the macular rash at the bottom. So how would you diagnose Orientia tutugamushi in the lab? Specimen. Remember, your specimen is always what the patient presents with. So if they come very early and you have to present with this, you can have the skin biopsy, lymphadenopathy. Lymph nodes will not find us talking about isolation of some artificial media. So serology has been the mainstay of diagnosis. So the Will-Felix agglutination test, because now you can use molecular tests like PCR. So above is a Will-Felix reaction. So of course, you're looking for agglutination to the left, top left. That shows positive and negative. There's no fluorescent test. Again, the drug of choice is doxycycline, chloramphenicol. In severe cases, combination of doxycycline and rifampicin, these are two drugs which are good for intracellular bacteria. And after infection, there is what referred to as an unsterile immunity. Go and read about sterile immunity and unsterile immunity, and so on and so forth. So sometimes when you're not able to do the diagnosis, you only have the Will-Felix reaction. Sometimes you start off on doxycycline, and there's usually a dramatic reduction in the symptomatology. So this has been used in areas where you do not have this. You give doxycycline and the patient not immediately, after some hours, starts getting relief from those symptoms. So prevention, of course, not exhaustive. You can only talk about prevention and control if you know how a bacterium is transmitted, and so how it can be, transmission can be avoided. Now, these mites are microscopic, as we said, so you cannot see them, and that is why it says here, avoid sitting or lying on bare ground or grass, because you cannot see them, but they will bite anyway. And of course, clearing of vegetation around dwelling places, because this is where the mites breed. Control, of course, it's standard. Now, the other genera are Ehrlichia and Anaplasma. Now, these are commonly studied in animal populations. If you look for Ehrlichia and Anaplasma, most of your hits will be for studies that have been done in animals. So the vet done quite a bit of work on Ehrlichia and bacteria, very similar to what you covered in the reticulate cells. And they lack important cell membrane components, including LPS and peptidoglycans. So when you notice the bacteria are towards the spectrum, if you are to look at this causes in microbiology, the causes of human infection. So you have the parasites, you have the bacteria, and you have the viruses. So Rickettsiae tend to be very close to the viruses. They have viral-like characteristics, but remember they have the nucleoid and the whatnot. So they're a bit different from the viruses, but they are very close to the viruses. So they also lack important cell membrane components, as we said. So HME and HGA have similar clinical presentations: fever, headache, and low white blood cell count, or leukopenia. So these show the two types of heart ticks. To the left is the lone star tick, so named because it tends to have a star-like mark on the back. In this case, it's white. And to the right is Ixodes scapularis. So HME tends to be more severe than HGA, but more or less the same. You have fever, headache, muscle pain, joint aches, skin, and which you know is a hallmark of any kind of diagnosis. What do these people do? Have they come into contact with? So we tend to see this, the studies that have been done in Kenya among the vet or the animal population, and have correlated the infection with humans. We tend to see this in farmers dealing with livestock or livestock keepers. So clinical suspicion or clinical history, what do these people do? Serology, again, these are obligate intracellular bacteria. PCR has been used, again, the tetracyclines are the drugs of choice, and rifampicin can be used. And very simplistic to say avoid bites. So of course you need to break down This, how do you avoid tick bite? You need to break them down for the person that you are advising. Now, the other very new genera, Rickettsiae and Neoalicia, known about them because they are still under investigation. So we have Rickettsiae senestus. Some of them don't even have names yet. So they are still Rickettsiae species. Infect nematodes as fish. Transmission to humans is raw fish, which I think is also becoming a bit more popular in the urban area. They are not falling under this. Okay, I hope that's clear. So helminths are worms. You can see them with the naked eye, transmitted by the hard ticks again. So you can see how important hard ticks will be. So Rickettsiae helminth, or it could be, maybe by the last time I was making these notes, they hadn't even named the others. So yes, and that's why you need to keep reading. Because of advances in sequencing and DNA sequencing. And so there are classifications and reclassifications of all kinds of organisms, especially the bacteria that have never been cultured because they're strict intracellular bacteria. So they're closely associated with rodents in which transplacental transmission occurs. So once you do entomology, this will become clear. What does transplacental transmission occur? It means future generations will also carry the infection. So probably the Rickettsiae helminthica that you're talking about could be that it was first isolated in a helminth, but it's not a helminth itself. So the other genus of interest is Coxiella. So people may get Rickettsiae by eating sushi. All I'm saying is you can get many things from eating raw things. So it's important to be careful about where you're eating this sushi from. So there has been an urban interest in eating these so-called, what's the word now? Upmarket tastes of food. So it could be, it's good to be careful. If you're going to eat sushi or any other kind of raw meat, it's important to be comfortable or to be aware of the hygiene practices of the establishments that you are going to. Okay, it's never a good idea to eat raw, but it depends really on where you're eating this from. So make sure you're going to, don't eat it from the roadside for sure, but make sure that you're comfortable in the experience of the establishment that you're eating it from. So they've been making it for years. Also look at reviews. They have not had any complaints from prior clients. So Coxiella was classified previously under the Rickettsiae, but as I said, as DNA sequencing continues, there is a reclassification of bacteria as we know more about the genetic makeup and where they fall. So it was reclassified under the order Legionelaris and the family of Coxillaceae, but we still look at it under this topic. So the genus is Coxiella. These are small, leomorphic, gram-negative cocobacilli. As we've already said, very similar to the Rickettsiae, it stains poorly with the gram stain, so we use the special stains. It's an obligate intracellular bacteria. And it's so hardy that it's able to live inside the acidic lysosomes without being destroyed by the reactive oxygen species, the nitrogen species that's supposed to destroy it. So it's able to survive inside the lysosomes. Now it causes Q fever. Q fever stands for query fever. And this is because for many years, the cause of the Q fever was unknown. Being a strict intracellular bacteria, in those days, DNA sequencing was not well established or established at all. Because this was during, I think, the Second World War, when the Q fever was first discovered. They could not isolate it in the lab. And so it was always a query, what's causing this fever? You rule out the known causes of fever, but you still cannot. So you're not isolating any of the common causes of fever, but this patient still has a fever. So what's causing it? Hence, query fever or Q fever. Now, this is another bacteria that also exists in two morphological variants. Remember, you've now covered chlamydia, and we have talked about. Do you remember what we've just talked about? So some of these bacteria exist in two morphological variants. Now, for Coxiella burnetii, we have a small cell variant, which is spore-like. And remember, spores, we covered spores are important in the survival of bacteria, or the spore-forming bacteria, but they are spore-like. They do not have all the characteristics of spores, but they serve the same purpose. They're able to survive harsh environmental conditions. And then you have the large cell variant, which is the intracellular form, and it's the one that multiplies inside host monocytes and macrophages. So it has been found in various hosts, mammals, birds, ticks. Now for human disease, the farm animals are the primary reservoirs, and it's excreted in urine, in milk, in feces, and in bath products. Bath products, especially both of humans and animals, tend to have high numbers of bacteria. So how does human infection occur? Remember, we have the spore-like small cell variant, and so inhalation can also skin contact and exposure of any of the bath products. So it could be a placenta, both of the infected woman or of the infected animals, and of course, blood transfusion. In case the donor had an infection, of course, we do not routinely screen for it. Now, this is another interesting bacteria because it is classified as an agent of bioterrorism. So it's highly infective, it has a low infective dose, and it can be transmitted through inhalation. So these are some of the characteristics of bioterror, agents of bioterror. So it can be released into an area and people inhale it. It has a high infectivity, and you only need a low dose for the person to get infected. So what is the pathogenesis of Coxiella burnetii? So it first attaches to host macrophages using ankyrin, which is an athesin. Then there's passive entry into the phagosome. Remember, for the Rickettsiae, we say there is induced phagocytosis. In this case, there's passive phagocytosis. Now, it delays the fusion of the phagosome with the lysosomes, and this is to give it the chance to transform from the small cell variant to the large cell variant. And once it transforms into the large cell variant, intracellular multiplication is then initialized inside the phagolysosome. There will be proliferation and subsequent rupture, and then they go on to infect other cells. So for those that haven't been ruptured yet, the macrophages are transported systematically. And Coxiella burnetii has tends to infect the reticuloendothelial system more than any other. So the liver, the spleen, the bone marrow, these are the most heavily infected. So a diagram showing what we have said in summary. So there is passive phagocytosis formation of the phagocytic vesicle, and it's able to survive inside the phagolysosome. So infection with Coxiella burnetii can be acute or chronic. So for the acute disease, it has a long incubation period of about 3 weeks. And there's then a sudden onset of severe headache, high fever, chills, and muscle pain. So there may be respiratory symptoms, but these are generally mild. And hepatosplenomegaly may be present in about 50% of these cases. So for the chronic disease, the most important or the most common presentation of the chronic disease in Coxiella is infective endocarditis. And this generally is found on the prosthetic or previously damaged heart valve. So which is the commonest bacterial form, a cause of infective endocarditis? Which is the commonest bacterial cause of infective endocarditis? Any ideas? Infective endocarditis?
That would be strep pyogenes.
Streptococcus. So someone says group A streptococcus, that's Streptococcus pyogenes. Streptococci in general, species of streptococci. So these are the aureus, acute staph aureus, subacute staph viridans. But it's generally the streptococci. So I think once you start doing clinical was reclassified, but still you'll find it still being discussed under the Rickettsiae. Now, this is one of the different ones that we have looked at today. Remember, all of them are strict intracellular pathogens, but Bartonella is a facultative intracellular pathogen, and the infections are ubiquitous among mammals. So it infects many different kinds of mammals. So many species can infect humans either through natural host or as zoonosis. Which are our species of interest? You have Bartonella bacilliformis, which causes Carrion's disease. Now, Carrion's disease is interesting. For those who are interested in medical history, go and find out how it got its name. So Carrion's disease has two manifestations, Oroya fever and Verruga peruana, and it's transmitted by the phlebotomine sandflies. So when you do
Hello.
what else is transmitted by the phlebotomine sandflies? Then you have Bartonella henseli. Bartonella henseli causes the cat squatch disease of the liver, and then you have Bartonella. So also trench fever got its name. Again, for those who are interested in medical history, you may go and find out how it got its name. But in summary, system a very severe disease. So nearly every erythrocyte or red blood cell is infected. And of course, because of this, there's severe reduction in the hematocrit. There's more than 80% destruction, and you expect the patient to present with signs of severe anemia. So pallor, fever, anorexia, malaise. And with severe anemia, you have new murmurs, so cardiac murmur, muscle pain, headache, and all the others that are associated with severe anemia. So the complications, there is high mortality in pregnant women and their unborn children. And you can also have complications in other symptoms. Now it has a high fatality rate, 40 to 88% without antimicrobial intervention. And you can have secondary infections because these tend to be very severely compromised patients. So they're not able to fight off any other invading infection. So you have salmonellosis, toxoplasmosis, all these, they can have secondary infections. Now, the other presentation of Carrion's disease is verruga peruana, which is milder and it's chronic. And it got its name because of these blood-filled nodular hemangiomas of the skin. And these are what are referred to as the verruga peruana or the Peruvian warts. It was first described in Peru, hence the name. And they tend to occur on the head and the extremities, and they persist for several weeks to months. So this is what the verruga peruana look like. These are hemangiomas. Okay, and then you have the fever. It causes chronic bacteremia, also an important cause of endocarditis, and it's spread by the pediculus humanus corporis or the human body louse. So you can see why it will spread among soldiers who are lying together in trenches, because this move from one person to the other, spreading the illness. So it's a 5-day fever. So they have 1 to 3 days of fever and they recover every 4 to 6 days. I think most recover at the 5th day and then they have a fever, and hence the name, the 5-day fever. So that's the louse, as we had seen earlier. So Bartonella henseli, as we said, causes a cat scratch disease. And this is transmitted through the scratch or bite of an infected cat. So what will the patient present with? Inflammatory lymphadenopathy and a papular lesion of the skin, which develops at the site of the injury. And you can see in this picture, this was the scratch. And you can see the direction of the scratch and the infective, the nodules where the clues were. Now, special training techniques does not also take the Gram-Stain well, so you use either the Jimenez or the James sustain. Now, this is a facultative intracellular bacteria, and so you can grow it on artificial media. And the media that is used is enriched blood agar, a slow grower, so 1 to 6 weeks in a humid environment, supplement with carbon dioxide to improve your chances of isolation. And because of these difficulties in isolating this fastidious bacterium, serological tests have been what have mostly been used. And of course now, more and more we are using PCR. These are very young growth of Bartonella, too young to be seen. Again, the drugs of choice are the tetracyclines. Macrolides can also be used. So prevention and control, it depends on what the patient has been diagnosed with. And so if it's trench fever, then if there are areas of overcrowding, then you'd advise them to avoid the overcrowding and to get rid of the lice and so on. Of course, cats that transmit cat scratch disease are usually not sick, so they are reservoirs for human disease, but they do not They do not manifest the symptoms themselves. Okay, so that's the Rickettsiae. We take a 5-minute break, then we take a 3 minutes break, then we do the introduction to mycology. Are there any questions on the Rickettsiae?